Hello and welcome everyone. Dr. Vineet and myself, Pradeep, are the Masterclass chairs today. Today we have some of the world-renowned experts here to help the 4 wonderful masterclasses, which we hope will quench your thirst of knowledge and sharpen your mind. We'll now begin with the Stone Masterclass. To moderate the session, may I now invite our eminent urologist from Singapore to moderate the session, Dr. Tan Yum Kang, Prof. Heng, Dr. Yui, and Dr. Palani. No need to be masked. Okay, to cheer up on the day, a big round of applause for them, please. Okay, may I now invite the moderators to introduce the session and the speakers. Okay, enjoy the session.
Welcome everyone. It's my great pleasure to welcome you to my hospital for this first SUA session, UROFAIR session here. We're starting a bit late, so we're going to move straight on to the talks. Our session this morning is on mask on. Okay. Mask off, right? Can. Oh, great. Mask off. For us, yay. Our first session here today is on stones. So we are going to have it a hybrid system as well. So some of our speakers will be speaking with recorded or dialing in. And we have live speakers as well. So to start the ball rolling, we have Dr. Khushad Ghani, who's going to be speaking on a single-stage stone-free rate possible with Moses technology. Dr. Khushad Ghani graduated from University of Leeds and was awarded a Master of Surgery thesis from the University of London for his research in percutaneous renal stone surgery. Following completion of subspecialist training in endourology at the Stone Unit in Guy's Hospital, he was awarded a Urology Foundation Scholarship and undertook fellowship training in robotic surgery in Vaticuti Urology Institute, Henry Ford Hospital, Detroit. Dr. Ghani joined the University of Michigan faculty in 2013 and leads the endourology program at the Ann Arbor VA healthcare system. So he's going to talk to us on single-stage stone-free rate possible with Moses technology. I think the screen's on the side, so.
Hello, I'm Khushad Ghani from the University of Michigan. I'd like to thank the organizers of the UROFAIR Congress for inviting me on this forum to speak about single-stage stone-free rate as possible with Moses technology. My relevant disclosures are noted here. In particular, I have some grant funding from Boston Scientific on work in the laboratory assessing holmium laser lithotripsy. In my talk today, I'm going to cover the following objectives. I'm going to describe what is pulse modulation with Moses technology. We'll then go over some of the advantages that we've seen in the laboratory in terms of how it's different from standard holmium pulses. I'm going to speak about some of the principles for high-frequency dusting technique for single-stage uretroscopy. I'll talk about some of the outcomes that I've achieved with Moses technology for single-stage uretroscopy. And so let's move on straight to what is the difference with holmium Moses pulse compared to the short pulse. Over the last 20 years, we've seen an evolution in pulse mechanisms where the short pulse, which has a high peak power, has transitioned to the longer pulse duration holmium platforms. And the advantage of doing long pulse is that it has less retropulsion because of the lower peak power. And what we now have with Moses pulse modulation is what we call the multi-pulse. So the pulse is split into two, so a proportion of the energy of the pulse is absorbed by fluid, allowing that second part of the pulse to have more impact on the stone. And the result is more fragmentation along with less retropulsion. And this is what Moses pulse looks like under high-speed imaging. There are 2 types of Moses pulses available with the Moses technology platform from Boston Scientific. One is Moses distance and one is Moses contact. And you can see the bubble profiles of this split pulse in these sequences here. This is a simpler schematic just to show the difference between the 2 pulses. And the main thing to understand is that the Moses distance pulse has 2 equally weighted large pulses compared to the Moses contact pulse, where the first pulse is a bit smaller in profile, followed by a second larger pulse. And these differences in the weighting and the sequencing of the pulses will have different impact on fragmentation. And so what are the advantages of using Moses technology? We studied this in the laboratory and published this in 2019, where we compared short pulse, long pulse, Moses contact pulse, and the Moses distance pulse on Bago stones with the laser fiber touching the stone on contact, fired for 200 seconds using a pulse energy of 1 joule and 10 hertz. And you can see at the end of all these experiments, we found that there was one pulse mode which led to more fragmentation. And that pulse mode was the Moses distance pulse. And so we found that this particular pulse was pretty unique, and it led to around 30% more fragmentation. We also found, as designed, that the Moses distance pulse led to more fragmentation when at distance. So in this graph, you can see that at 1 millimeter, there is double the fragmentation when you're using the Moses distance pulse compared to the short pulse. But the maximum fragmentation is on contact. But this is an important concept to understand, because with dusting technique, we found in the lab that when you're doing a dusting technique, surgeons are not on the stone all the time because of the constant movement with the fiber on the stone. Around 50% of all the laser firing is at more than or 1 millimeter distance. And so therefore, a pulse like Moses distance is ideally suited for kidney stone dusting. And that's why I call the Moses distance pulse Moses kidney. More recently, the investigators at Duke, led by Mike Lipkin, studied the differences between Moses distance and other pulse profiles, such as the quanta vapor tunnel, which is a very long type of pulse. And you can see here that Moses distance, which was in purple, was superior to the Moses contact pulse, which is in green, and significantly superior to the vapor tunnel pulse. And this is at 0.5 millimeter distance. And so these findings replicate what we found when we were assessing the advantages of these different pulses. Another advantage of using a Moses distance pulse is that if you're doing a technique such as popcorning, where a lot of the firing is occurring at distance, it would be advantageous to use this type of pulse. And so we studied this in the laboratory and published this paper in the World Journal of Urology. And what we found when we used 20 watts of energy and we compared it to short pulse, Moses distance at the end of all the experiments had less large fragments. And we know that having less large fragments is really important for clinical outcomes. That prior study I just showed you was done on Bago stones. And so one of the criticisms is that maybe the results are different when you check on calcium oxalate stones. So we did a similar study that was recently published in Urology, where we looked at Moses contact, Moses distance, short pulse, and long pulse, and we assessed it on calcium oxalate monohydrate stones, dog stones. And what we found is that the Moses pulses led to significantly fewer larger fragments compared to long pulse. So again, another advantage of using pulse modulation for laser lithotripsy. And this is another advantage, which is the impact of these split pulses on the fiber tip. It's much, much more gentle on the fiber tip and burn back. So if you compare to short pulse or long pulse, the Moses pulses lead to significantly less fiber tip degradation. So let me just pause for a second and give you a summary on the findings in the lab regarding the Moses technology multipulse. Moses distance pulse leads to more fragmentation, and therefore it would be faster. There is more fragmentation at distance, and this is ideally suited for the contact phase of dusting. This more fragmentation at distance means it's also suited for the pop dusting phase of uretroscopy. Moses pulse results in less large fragments, and this would mean better clinical results, because as we know, fragments that are larger than 2 millimeter in size are the ones that cause problems in terms of reintervention. And the other striking finding on using multipulse is the protection on laser fiber burnback. And we know if we can prevent this, this will also lead to an improvement in fragmentation. So altogether, all these factors improve the efficiency of laser lithotripsy. So I'd like to now talk about single-stage uretroscopy and some of the aspects with regards to technique for that. So some of the principles for uretroscopy for kidney stones are presented here. The first thing when I'm dealing with medium to large size stones in the kidney that I'm treating patients with uretroscopy is I set expectations. Sometimes the stone is very large. They may need to have a staged procedure. But most importantly, I set expectations on the need for stenting, especially for the larger stones, and the symptoms that one can expect to get from uretroscopy. If the patient is not pre-stented and the stone is more than 1 centimeter in size in the kidney, I try to use a urethral access sheath. And the reasons for this is that the urethral access sheath will allow me to use higher flow rates, which allow me to see better throughout the dust, allow me to do a faster procedure. And these higher flow rates will be mitigated if you're having an access sheath in terms of intrarenal pressure. In terms of access sheath sizes, I use smaller sheaths if the ureter is unstented, but larger sheaths if the patient is pre-stented. My exit strategy for pre-stented patients, especially if the stone is less than 1 centimeter size, I always try and aim for stent omission. But if the stones are between 1 and 1.5 centimeters, I often will use a stent on a string, which I'll place for 5 to 7 days. If this stone is more than 1.5 centimeters, I tend to stent patients, and I will prefer silicone stents in that scenario. If the stones are larger in size, and that's around, usually for me, a threshold of 2 to 2.5 centimeters, I usually plan for a staged procedure with that second procedure 2 weeks later. And very importantly, I manage expectations and symptoms, and I provide all patients alpha blockers, anticholinergics if they have a stent place, and non-steroidals for pain relief. We recently looked at stent omission in the state of Michigan, and we developed our own criteria in our group called MUSIC, and these are for the stent omission criteria, and these are available on the musicurology.com website. And you can see here that we have different size thresholds. So if the patient is pre-stented, stones that are less than 15 millimeter in size are suitable for stent omission. If the patient is not pre-stented, stones less than centimeter in size are suitable for stent omission. And there are other factors, as you can see on this slide here. One of the things that I found with high frequency, high power lasers is that we're able to do less staged procedures. And we presented this work at the AUA in 2016, where we compared 28 patients with kidney stones treated with 60 to 100 watt lasers compared to 35 patients with the 120 watt laser. We found that with the 120 watt laser, our zero fragment rate was significantly improved. It was at 66%. Compared to 39% with the older lasers. There were no differences in complications, but most importantly, with the higher power laser, with the 120 watt laser, we're able to do we were able to do less frequent staged procedures. So what are the results with Moses technology? We recently looked at the results in our group here, single surgeon series. So these were my patients, 29 patients who had a single kidney stone undergoing flexible uretroscopy with the Moses technology platform. And we found that the stones were an average size of around 1 centimeter, and the operating room time, so that in the room and out the room, a mean operating room time of 32 minutes. Our zero fragment rate was around 79%. And importantly, many of the residual fragments were small in size, less than 1 millimeter or 1 to 2 millimeter. And the greater than 2 millimeter fragments rate was only around 8%. So some really good outcomes using Moses technology for single stage, single kidney stones. Moses has advanced where there's now Moses 2.0, which provides 120 hertz. And we looked at 12 consecutive patients undergoing laser lithotripsy for kidney stones with the Moses 2.0, and we found similar results, a mean operating room time of 36 minutes. The need for stenting was only 25% in this cohort, and again, we found a complete stone-free rate on imaging of 82% using this system with very low complication profile. This is a video that shows a 1.7 centimeter left renal stone at the UPJ treated with the Moses 2.0 system. My principles are I place the patient in Trendelenburg position, so head down. I'll then use the scope to nudge the stone from the renal pelvis into a more optimal location, such as the upper or interpolar region. In this particular case, the stone was calcium oxalate based, and so I started at 0.3 joules and 120 hertz to do a contact phase of dusting. And the principles here are to keep moving and to actively interrogate and debulk the stone. But at some point, the stone will fracture and crumble into multiple pieces, and then we do pop dusting phase in a calyx. And for this, I like to use 0.5 joules and 80 hertz with Moses distance. In this particular case, throughout the 1.7 centimeter stone, I had an access sheet placed. And then the pop dusting phase usually is around 30 to 40% of the total operating room time, with the goal to get fragments less than 1 millimeter in size. And at the end, if you have any larger fragments that have not been optimally dusted, there's no harm in taking 1 or 2 pieces out with a basket. And so this is what it looks like at the end, and you can see 1 or 2 fragments are retrieved. This is an example of a single-stage uretroscopy for a large right-sided Staghorn stone. And you can see the CT scan showing the large right-sided Staghorn stone in this patient of mine. And we treated this with a urethral access sheath placed. We used the Moses technology platform to do laser lithotripsy. We used a setting of 0.3 joules and 70 hertz to begin, and then we increased the power during the case. We completed the case with pop dusting with Moses distance at 0.5 joules and 80 hertz. Total lithotripsy time, that's total on and off with all the pauses, was 33 minutes. Lasing time was 15 minutes. Total energy noted here. And several fragments were removed at the end for analysis. The patient was reluctant to have a second procedure, so I got a CT scan 4 weeks later just to see if a second procedure was needed, and to great result, which is very little, some small fragments in the lower pole. And so we decided not to do a second stage. We removed the stent, and then 6 months later followed up with another CT scan that showed complete stone clearance in this scenario. This is an example of a large upper urethral stone, 15 millimeter stone, treated safely with the Moses technology platform. So this patient had an impacted 15 millimeter stone. In this scenario, we use low power settings. I don't use an access sheath. I use settings less than 9 watts. I use a combination of fragmentation with the Moses distance and Moses contact pulses. And here, lithotripsy time was 19 minutes, lasing time 6 minutes. And the total operating room time in and out the door, 42 minutes, which was really fast for this type of stone. So I'd like to close and thank you with my summary points from this talk. Moses distance pulse leads to more fragmentation, so it's faster. There's more fragmentation at distance, meaning it's excellent for contact dusting. It's excellent for pop dusting. It leads to less large fragments, which is better clinical results. There's less fiber burn back, so it's more effective fragmentation. And as I mentioned before, all of these improve the efficiency of laser lithotripsy. And with high power, high frequency systems, we're able to treat these larger kidney stones uretroscopically in a single procedure. In my hands, a single kidney stone, this doesn't take more than 30 minutes in the operating room. And the 2.0 Moses system now allows us to do frequencies as high as 120 hertz. And it's in particular, a system like Moses allows us to do effective and safe, efficient treatment for impacted urethral stones. Thank you very much for the opportunity to speak. I'm looking forward to the discussion and questions later on in the session. So thank you.
Okay, thank you very much, Dr. Ghani. So moving on, because we're taking the questions at the end of the session, we have Dr. Sabnis. Just give me a moment. Okay, I can introduce Dr. Sabnis. It gives me great pleasure to introduce Dr. Sabnis. He's from Nadiad, Multibai Patel Urological Hospital. I did my fellowship there, and he's a great teacher, a great academic person who's well published, and he teaches pretty much a lot of residents as they get through their programs, and he's well known to the Society of India and is the current president there. So it gives me great pleasure again to introduce Dr. Ravindra Sabnis for the next talk.
respected chairpersons, and my dear friends. At the outset, I would like to thank the Singapore Urology Association in general and Dr. Vineet Gahar in particular for giving me this opportunity to be the part of UROFAIR 2022. I'm going to talk today on the how shock pulse has revolutionized the energy devices, especially when it comes to PCNL, and what is the future. Well, when we talk of what is ideal stone breaking device in PCNL, it should fulfill following criteria. It should be powerful enough to break even hard possible stones. It should have effective simultaneous suction, which is now very, very important when it comes to PCNL and especially when it comes to a bigger size stone. It should be of a variable sizes because it can be used in conventional PCNL, standard PCNL, or even the mini PCNL. And of course, any device which has to become popular has to have less maintenance and low cost. So these are all ideal features which a device must have. Now, if you see what are the current energy devices which are available, mainly it revolves around the ultrasonic lithotripsy, pneumatic pits plus ultrasonic, that is EMS Swiss lithoclast master. And now the laser has become common and popular, low power or a high power. So these are currently available energy devices even for the PCNL. Now let us see one by one whether there are any problems and why they are not completing the criteria of the ideal energy source. If you see ultrasonic, which was the first energy device which was invented, but unfortunately it has very high wear and tear. It has got very high maintenance. The transducer goes on damaging, very frequent damages. Burr is oscillating, keep at the damage, and therefore it causes damage. The complex connections when you want to connect the machine, and even though it is a most powerful energy source and it has got a very powerful and a simultaneous suction, it has gone into the unpopularity because of this problem. When pneumatic came in, that was considered to be a revolution in the energy device for stone breaking because it was a simple technology. There was hardly any maintenance, very powerful to break hard stones. But the flip side was that there was no suction and it had to be, if you have to use, it was to be attached to lithovac, which is sort of a compromised suction. Lithoclast master was thought to be a revolution, but unfortunately not so, because it was combining ultrasonic and pneumatic, thinking that there will be both advantages of both the sources. Yes, it is powerful stone breaker, suction is possible, but what has happened in combining both this is that the size of the probe has become too long, and because from the ultrasonic burr inside there is a lithoclast probe, and therefore the lumen gets compromised, and therefore the effectivity goes down. When the laser came in, everywhere it was a laser which was used. The advantages was that it was smaller size fiber, flexible fiber, and therefore with mini-PCNL it was used very frequently. But the problem of laser is the high cost, high maintenance, and of course it is a very small, very slow in breaking the stone. When it comes to a bigger stone during PCNL, large bug stones, it has a problem and of course no suction. So that was the problem. So if you see all the energy sources which are currently used, they are far away from the ideal, and therefore the quest to find out best energy source continues. And when shock pulse is now been introduced, it is considered as a breakthrough in breaking the stones because it addresses most of the above mentioned concerns. Now let us see one by one what are they. And first of all, let us see what is shock pulse. The shock pulse is a combination of ultrasonic and ballistic energy. It delivers a constant ultrasonic energy at the probe tip. Intermittent, there is a ballistic energy at the tip of the probe, and combination of both breaks the stone and sucks the fragments very effectively. The beauty of this particular device is that both these energies are delivered through the same probe. So there is no difference like lithoclast master, and therefore there is no compromise in the lumen. Large lumen is available for sucking the fragments or the powder, whatever you make. So is the shock pulse a revolution? Well, if you have to evaluate from that standpoint, we have to evaluate the shock pulse in the following parameters. What is the effectivity and efficacy and success rate if you use shock pulse? Whether it is a safe, device or not. even if it is used for prolonged time, whether the safety is compromised or not, whether it is versatile, meaning thereby whether there are various sizes of the probes are available or not for the standard PCNL or for the mini PCNL, whether the device has ergometric design or not, whether it is easy to use, and what is the cost and the maintenance. So these are the parameters on which the energy source is to be evaluated. And let us see shock pulse, how it behaves. Now, if you consider the efficacy and effectivity and the success, yes, shock pulse is a revolutionary technology, because as you can see from this graph, this is how the ultrasonic energy is delivered at the tip of the probe. That is 21,000 hertz per second. So that is the frequency which is delivered. And if you see this brown, that is the lithoclass or the ballistic energy which is delivered. So that is by 300 hertz per second. So in combination of these two, it is a very effective way of breaking the stone. Now, how it breaks the stone? When the probe comes in contact with the stone, the piezoelectric excitation of a crystal causes rapid oscillation of a probe to fragment the stone. Whatever fragments and powder which is formed at the 21,000 hertz per second frequency, that powder is effectively sucked out and the fragments are removed effectively. And in between the 300 hertz per second, the energy which is developed from the ballistic actually creates a cracks in the stone, and that enhances further effectivity. So if you see this combination, it is a very effective combination from the point of view of breakage of the stone. Now, this has been proved also in the clinical setting, where this is the recently published article, and they have evaluated this shock pulse, which is a combination of these two energy, against the ultrasonic and the pneumatic as a solo energy device. And what they have found is that shock pulse was more efficacious than the ultrasonic or the pneumatic, which is in comparison with the isolated energy source. Now, we have been using this energy source for quite some time, and let us see this index case, a very large bulk Staghorn type of a stone, which has got the fragments in all the calyces. And if you see here, the stone appears to be infective in nature, and especially in such situation, the fragments which are formed can be sucked out very well, especially when you have the infective type of stone. The fragments need to be sucked out very fast, and that is very, very beneficial when it comes to shock pulse. Now, how effective it is, let us see from this video that the puncture is done in a regular fashion. The tract is dilated. This is a Staghorn stone. So standard PCNL is used, a 24 French size tract. And once you introduce the nephroscope, and once you introduce this the probe, which is of a 3.3, 3.6 mm size, you can see here that the probe is actually breaking the stone very effectively. And as the fragments are being formed, as the powder is being formed, you can see here that it is effectively sucked out. We have done plenty of cases in this with this shock pulse device, and what we have found that not only the breakage is powerful, but the suction is extremely effective. And in effect, what happens is that your need to remove the fragments with the forceps actually goes down. Now you can see that this is actually a semi-edited or the unedited type of video, wherein you can see that the fragments are being sucked out, and continuously, once the probe is in active mode, you don't need the fragments to be sucked out. At the end, you may remove one or two fragments just for the analysis. And you can see here that in front of your eyes, the stone is actually getting morcellated. So that is the kind of effect which is produced by the shock pulse. And in fact, we have presented the videos that in a Staghorn stone, it is a forceps-free PCNL that is possible only by the shock pulse energy. Similarly, this is the mini PCNL, in which the probe is a smaller size, and even though this stone appears large, the 1.8 mm size probe, this is a mini PCNL introduced, stores a 15 French size sheet and a 12 French nephroscope, and you see here that how effective it is in breaking the stone, and even in the smaller size of the probe, The suction is quite powerful. You see here the ergometric design, very easy to hold the probe, very easy to introduce, very lightweight. And in front of your eyes, the stone gets fragmented, stone gets sucked out, and the complete clearance can be achieved. So that is the beauty of this. Since the energy source is very powerful, your operation time decreases, your morbidity decreases, and your number of cases which otherwise you would have done in two stages can be done in one stage. And a tubeless PCNL and the mini percu is very much possible, because you are sure that everything is cleared completely, and in front of your eyes, these stones are cleared up. Another thing is why you consider this as a revolution is the design of this energy source. See, it is a simple device. It has a transducer to which the probe gets attached. It can be fitted, and it is just a plug and play type of design. You don't need any clumsy attachment. Once you attach, your probe is ready, your transducer is ready to be introduced, and the stone can be broken up. Another important revolution is that everything is hand controlled. The surgeon himself can divide whether you want to high setting or a standard setting. This is for suction. You can reduce or increase the suction. Everything is in your hand. And over and above that, the transducer design is very ergometric, very lightweight, so there is no fatigue to the surgeon. The most important thing is different sizes of the probe. You can see here that you have 3.7 mm probe, 3.4 mm probe, 1.8 for mini PCNL, for URS, for bladder stone. All sizes probes are available. And therefore, whether it is a standard PCNL, whether it is a mini PCNL, you don't need to change the devices. You don't require multiple investment of different devices for different type of surgery which you are going to do. One single device with different probe is effective in all the branches. However, there are flip side of that. There are some problems and disadvantages of shock pulse as of today. Currently, the probes are very delicate. It will not last for too many cases, but they have introduced the carbon-coated probes, which are black-colored probe, and they are supposed to be very sturdy. We have used it, and it lasts for quite a number of cases. So that is one design which they have manufactured, and that definitely is beneficial in future. The other problem which comes in is the fragments which they block the probe, and that requires repeated cleaning. Some innovation needs to be done in which this is automatically flushed out, or this problem is not there, which otherwise consumes a lot of time to disconnect the probe and then flush it out. So that certainly requires some innovation. The additional innovation which is possible and which can be done in future is the digital adjustment of the power and suction. At present, you have two settings of the high and standard, and you have the ring in which it rotates either from minimum or the maximum suction. But certainly a digital control, maybe on the outside, on the energy source or the console, is perfectly okay. But that will give the exact adjustment as to what can be done in future, and you can select what is the power of energy which is required, what is the impact which is required, what is the suction which is required. So fine adjustment is possible. But as of today, if you consider, then the shock pulse as an energy source is very, very promising. It probably has revolutionized the way in which the stones can be broken up, especially when it comes to PCNL. Thank you very much.
Thank you very much to Dr. Sabnis. So it gives me great pleasure to introduce our next speaker who is here with us in person. Dr. Ben Chu is Associate Professor of Urological Sciences at the University of British Columbia. He's also the Chair of Research for the Endo-Urological Society. He consults for several companies, and he has also worked on several projects, including the Soltive thulium fiber laser, the shock pulse lithotripter, and the LithoView Elite Uretroscope. He has also worked on the Monarch robotic uretroscopy platform, as well as a degradable ureteral stent. Dr. Ben Chu, please.
Thank you. It's a great pleasure to be here. Thank you again. I always enjoy coming to Singapore. So I'm going to talk today about thulium fiber for urolithiasis. These are some of my disclosures. I think the most relevant one is highlighted here because I'll be talking about the Soltive laser from Olympus. We all know that thulium fiber, holmium YAG comes at about a 2120 nanometer, and thulium fiber is just below that at 1940. So it's very similar, but why is this important? In fact, some of the laser goggles you have for your holmium machine will actually work for the thulium fiber. But because it's a little bit lower and closer to the absorption of water, this actually does a few things. It actually helps with coagulation of tissue. So sometimes when you accidentally laser the kidney a little bit, it won't bleed. But there's a theory that can actually help in absorption of water, that it may actually help with the fragmentation of stones, based on the fact there may be some small packets of fluid inside of the stone that will then help fragment it faster. Now, what is the main difference? So, Dr. Traxer and I have been involved in Olympus from the beginning. And when you look at dusting, so this video on the right is from one of my previous teaching videos when I would teach ureteroscopy. And we had to learn all these tips and tricks, so avoid producing large fragments for dusting, keeping it off the stone a little bit, going from the edge to the middle. And then you can see on the left, this is, I think, a PGY1, a first-year trainee doing it, where essentially you don't have to have all those little skills, all those little tips and tricks to sort of finely manipulate the scope in order to get it into those fine little pieces of dust. But I'll give you my take-home methods here. This is the message that these are the settings that I've started to use. I don't think these are the ones that I use, but I have to preface this with that there are so many settings, thousands of settings that you can use. Some of them are too high and dangerous, as Dr. Traxer and I will point out to you, but some of them are needed, more data is needed to figure out what is the most efficacious. But these are the ones I kind of start with, and in the ureter, never go above 10 watts. So one of the cases here, this is one of the things I wanted to show you at the beginning here. This is a large stone in the renal pelvis right there. And one of the settings that we had at the beginning, I usually start around 0.6 and 30. And I want to break it up into fragments. And then after that, then I want to pop dust. What you find is that the pop dusting for holmium YAG is never quite as good. So with the thulium fiber, it's very good. Now, the other caveat I have to this, compared to Dr. Ghani's lecture, is that I haven't compared this to Moses. We just got the Moses machine, but I don't have as much experience with the Moses. So from all accounts, they seem somewhat similar, but I'll show some data on Saturday suggesting that the TFL is a little bit more efficient and faster. So these are my main settings at 0.6 and 30 to break it up into chunks. I'm still painting the stone a little bit, and then afterwards, when we go to pop dust it, I'll then go to 0.1. Now this is at 45 watts. I think this is a little bit too high. I've gone down from this now, and I'll go to maybe 0.15 and 200, usually 0.1 and 200. I think this high frequency is maybe a little bit too high and go down to the lower energies. But other settings work as well too. So when you use 0.15 and 14 and 0.1 and 20, so only 2 watts. I got these settings from Dr. Mantu Gupta in New York. He said he doesn't really use more than 2 watts. And this seems to work well as well too. And it'll be interesting to hear what Dr. Traxer's settings are. But when you use this setting here, it also works. And I don't even go above 10 watts here. Oops, sorry. There we go. So when we go here, this is 2 joules and 4 hertz, so 8 watts. You'll also find too that this actually works quite well. And no 1.5 and 14 hertz in the kidney as well too. So I'm never going really above 20 watts and keeping it below 10. And you'll find that it breaks up quite well, depending obviously on how hard or how soft the stone is. So you'll see that even these low settings work really quite well. And the fact that this machine can go up to 2,400 hertz, I don't think you really need that. So here's a large stone in the left renal pelvis here. And again, I'm starting at 0.6 and 30, which is sort of my usual that I like. So I'll even start a little bit lower, sometimes at 0.3 and 30, and then see how the stone goes. And I'll try to keep it as low as possible. You don't always have to go very fast. You don't always have to, take your Ferrari out and go 200 kilometers an hour every time you just start. You can actually start more slowly and then see how things are. So if it's breaking at 0.3 and 30, 0.4 and 30, I'll keep it there. 0.6 and 30 to break it up into pieces. And then for pop dusting, you can see that I had it at 0.2 and 300, or 0.2 and 100. So for ureteral stones, I think it's really important we keep it below 10 watts. So this one, I was coming out of the kidney, just examining the ureter, and then I found this stone that was actually embedded. We even had a ureteral access sheath, and the ureteral access sheath actually went up past this stone. So you'll see that I had slightly higher settings on here at 30 watts. So what we ended up doing was we ended up making it, we ended up getting it loose first. I wanted to see if I could basket it out of the access sheath, because I don't like to leave stones in the ureter, because I think this can cause a lot of granulomatous reactions and then eventually a ureteral stricture. So we got it out of the ureter here, and then you'll see that we turn it down to less than 10 watts, even at 1 and 10, even lower here I was doing 0.3 and 12 on the other side, works really well. Make sure you have cold irrigation and don't laser all the time. I think even though I'm below 10 watts, you don't want to just stay on that pedal the whole time. This laser makes it really easy to just laser the entire time because there's no retropulsion, there's really good pop dusting, but I think you can really heat up that irrigation fluid, and you obviously want to avoid any type of stray lasers onto the tissue as well too, which can induce a stricture. So I'm really trying to stay in the middle of the ureter here and not trying to work from the edge in like you would with a kidney stone. You just want to stay in the middle, and you want to basically break this up into small pieces. So this one I did at 1 and 10, and after that it broke up. Or then what you can do is push it up into the kidney, where you can try to get it into a calyx and then use slightly higher level as well too. What about embedded ureteral stones? You'll see an embedded stone in the proximal left ureter here, pretty large, quite a bit of hydronephrosis. Sometimes I like to deal with this with a percutaneous nephrolithotomy, but you can see that the tissue has grown really into the stone here. So I'm only using 3.6 watts, 0.3 and 12. You don't need a lot of energy. Stay in the middle. Don't laser the whole time. Give the ureter a bit of fluid, a bit of cool fluid to kind of cool everything down. At first I couldn't get my safety wire by. Now I have a safety wire there, and then I'm going up beside the safety wire. In case anything does happen, I will just stent and come back another day. I think too what Dr. Ghani said is very important, to always prepare expectations. I think every patient should know that they may just get a ureteral stent, and that you may have to come back another time. Now, what about specialized cases such as upper tract urothelial carcinoma? So here's we actually, the patient had a stone, but also had a tumor that we didn't know about. So I basketed this out because it was quite papillary, removed it from the access sheath. It turned out to be low grade. I removed out as much as I could to debulk the stone. And you can see that it wasn't a very lot of tissue below it. And then I put the thulium fiber. So this is a great laser for lasering tissue because it is so coagulative. The one thing I found with Homium YAG is it just caused a lot more bleeding. I think with Moses, you get a lot more coagulation, but with this one, just keeping it down to less than 20 watts. And all the other ones, by the way, I kept it short pulse. When you want to get more coagulation, I put it on medium pulse. So the more coagulation you want medium or even long pulse, which is what I've put here. And try to keep off the tissue a little bit so you don't go too deep, and then just basically fulgurate that area. This patient is now been tumor-free. So this is a real dusting laser. And one of the criticisms sometimes you get is that shouldn't we always basket out a piece for stone analysis for future stone prevention? And this just got accepted into the Journal of Endourology. And what Dr. Traxer did was he actually went in and actually aspirated through the ureteroscope and took out the little bits of sand that came out and had that analyzed. This, along with morphologic analysis, shows that when you look at the stone, you can actually tell and actually helps your stone composition. So you don't need to basket all those pieces out. So that also saves you a bit of cost on your disposables as well, too. Now, the other thing Dr. Traxer did was looking at thermal injury and efficiency inside of an in vitro study. And what he did was he used plastic ureteral models. He used a 150 watt holmium YAG versus the thulium fiber laser. And he used a 24 watt versus 6 watt systems and did them at different types of frequencies and different settings. 5 junior trainees and 5 senior urologists. They looked at the type of ureteral damage and ablation rate inside of using Bago stones. So with all settings, the TFL ended up having a higher ablation rate than the holmium did. But in both lasers, there was higher ureteral damage in the higher wattage. So the more energy you use, just stray laser energy, and obviously this wouldn't get the sort of heat from the fluid, but this is just stray energy. When you have higher frequency, it's a little bit harder to control that. And obviously experience. So the junior urologist had more damage to the ureter than the senior urologist did. So from this, this is a very good quote, I think, from this article. There's a higher stone ablation rate, reduced operative time in higher power settings, but you can actually get more thermal damage from that, particularly in unexperienced hands. So you certainly don't want to do that. So when I first used the thulium fiber laser, I put out this tweet, which was my pinned tweet and got my most viewed tweet ever, actually. Well, actually my second most viewed tweet. And it showed that 0.6 and 60, worked really well. And then after, doing some more research and listening to some other people and worrying about thermal damage, I now think that 0.6 and 30 should be the highest you would go, and then 0.1 and 200. I might go up to 0.15 and 200 for 30 watts. So this is my main takeaway from this. And looking at the safety of all this, I think that the really big thing is that really we should be looking at these types of settings. So in summary, my tips for this, other things that I'd like to tell you about is that I find that sometimes the laser fibers, particularly if you're using the 150 micron, which I really do like because you get more irrigation flow through your ureteroscope. There's just more energy, more room in the channel. If you use a device like this where you can screw it open and put the laser fiber in, no problem. For other ones that have a bit of a seal on there, sometimes the fiber can snap when you do that. So what I'll do is I'll actually just cut off a little 5 millimeter ureteral catheter and insert it through the seal here and then put the laser fiber through that, and that way it doesn't break. And then the other thing to do is to find your favorite settings, use presets, and then save them on there. That way you can recall them, the nurses have an easier time, and you can do so many different settings if you want to. The main thing, though, for safety is the heat. There's a heat map of Singapore. It can get pretty hot in the kidney as well, too. So, the nurses used to use warmed irrigation because they didn't want the patient to get cold. I use at least room temperature irrigation, if not cooled irrigation. Keep it running. Don't turn it off. People sort of turn it off because they don't want the retropulsion. There's very little retropulsion with this. And using a ureteral access sheath, as Dr. Ghani said, not only helps with your visualization, but will also help with the flow going in and the flow coming out too. And it's so easy to keep your foot on the pedal the whole time. I don't know what the proper amount of time is, but I sort of say maybe 20 seconds max, come off for 5 seconds to let it cool down, and then go again. It also lets you determine what the size of the fragments are, particularly if you're pop dusting. You want to see if there's any large fragments left in. So start low, ramp up. Don't go higher than 10 watts in the ureter. And the higher wattage does not result in higher breakage. So you shouldn't just crank it up to 60 watts or 120 watts for your holmium. You need sometimes low energy, sometimes a bit higher frequency, but you don't always need that higher frequency. It really depends on that stone type. when you get fiber burn back, you basically you should actually safely place further away on the stone and tissue. And the short pulse of thulium fiber is around 200 milliseconds, which is still longer than the longest pulse of holmium YAG. That's without the Moses pulse modulation. So there's a lower peak power. It's really good for dusting. A little bit harder for fragmentation. And I wouldn't throw out your holmium YAG. Sometimes if you really want that fragmentation, you want to break it up into pieces and basket out, like severely impacted stones in the ureter, stones off in a calyx where you want a little bit of side firing because the thulium fiber really does come out quite straight. If you want a little bit where you can't quite reach the stone in a calyx, I still think holmium YAG is very useful in those instances. And this is just the slide I showed you at the beginning of what I really like, the 0.6 and 30 at 18 watts and the 0.1 and 200. I will go up to 0.15 and 200 for 30 watts for harder stones for pop dusting. And then other settings work really well too. So 2 and 2.4, so even 8 watts really works well. The ureter, please stay below 10 watts. 0.1 and 20, 0.5 and 20 work really well. And just to quote an entertainer from originally from Pakistan, you know, no one really knows what they're doing. I'm supposed to be up here as an expert, but there's so many different types of settings you can do. I can just sort of tell you, don't go over the speed limit, please. And I think we need a bit more data and more research to find out what's going on with that. Thank you very much for your attention.
Thank you, Dr. Chu. So, 3 nice lectures on energy devices. Now we're going to go on to pediatric urology, and for that we have Professor Bhaskar Somani. I think he's going to be dialing in, right? Sorry. Well,
I'm here.
Yes, Prof. Somani is a member of the Bowels Academic and Endourology subsections, is also a member of the European School of Urology and Urolithiasis groups, many papers and book chapters, and he's going to tell us about RRS in pediatric urology. Professor, please.
Thank you very much. It's a pleasure to be here at the UROFAIR, to Vineet and the rest of the group. So I'll just share an experience regarding RIRS in the pediatric urology setup. And the question is better lasers and smaller scopes the answer? These are my relevant conflict for the talk. So EU guidelines, let's see what the guidelines have to say for pediatric stones. In children, you have the indications which are similar really to adults. For ureteral stones less than 1 centimeter, you have a shockwave lithotripsy with uretroscopy as an alternative. Renal stones, again, shockwave lithotripsy as opposed to uretroscopy, but uretroscopy is an alternative in pediatrics. And then for large stones, yes, PCNL as in adults. And you do have to really offer metabolic evaluation and recurrence prevention for pediatric patients. And then the evidence of flexible ureteroscopy in terms of stone-free rate, retreatment rate, complication rates is really acceptable and comparable to adults, especially useful for low pole stones where the anatomy is unfavorable. And then there's some predisposing factors, which is young age, I would say probably less than 3 years, cystine or large stones, and if they're not pre-stented, especially under 3 or 5 years cutoff. And then again, they're comparable to PNL, but with a slightly lower stone-free rate. For larger stones, less radiation, but also lower complication and shorter hospital stay. So there's a trade-off there between stone-free rate and the complication, etc. Worldwide, we know that uretroscopy has really taken off and shockwave lithotripsy has come down. And we see a similar trend in pediatrics. And when we look at the intervention trends for pediatrics, again, uretroscopy and minimally invasive PCNL have really taken up in terms of whatever is published. So look at the holmium and the thulium lasers. If we talk about lasers and how they have evolved, I think they've had 2 great laser talks. I'm not going to go over some of these because it's already been covered with holmium and thulium lasers, but I think they have revolutionized pediatric ureteroscopy as in adults. The settings, we have heard a lot about the pulse duration, energy, and frequency, and I think it's the same I think essentially you need to know what settings work in your hands, and of course be careful of, too much power and which can generate heat. But you should be knowing what you use. And I do think that pre-settings, at least in my hands, are not as good. I like to change the settings based on where I'm working and what type of stone I'm working on. And know your limits, know what dusting and fragmentation and where the stone is and what works for you. Laser fibers, again, for kidney stones, start from the center and go to start from the surface, go to the center. For ureteric stones, the other way around. Fragmentation, dusting, popcorning, I would very often change my settings during the procedure itself. So I might start with dusting and then go to fragmentation and pop dusting. And again, really it depends on the context, on the type of stone. But I think I wouldn't start to finish do it in one setting. I would very often change the setting. And towards the end, most likely, if it's in the kidney, go to pop dusting, because that really gives you the best results. I'm not going to show the videos because I think we have already done that. But this is my typical setup. I normally sit down to do my procedures with dual pedal. I've got the Moses 60 watt and also the 100 watt holmium lasers. And I think, again, I do think that slightly high power compared to low power probably works better. We have looked at, this is now published, low versus high power. And essentially, this is in adult patients. But when we talk about the laser energy, I think even for larger stones, the operative time was much shorter, stone free rate was much higher with the higher powered laser compared to 20 watt. And the complications rate infectious complications rate were much lower. So I think for us, I think we are moving towards slightly higher power, but again, that doesn't mean you always use a very high setting. But I think having a high frequency and high power does help. Dusting and pop dusting, we heard in a couple of talks about dusting and pop dusting. This is one of the initial papers we published about 4 years ago. So we had 50 patients with large stones, mean diameter of 2 centimeter plus, use dusting and pop dusting, operative time just over 50 minutes, and really good stone free rate. And I think they will become new benchmarks, especially with the modern lasers, better optics and better settings for large stones and probably bilateral and multiple stones. And this is what we do in terms of pop dusting. So we start with dusting at the periphery, and then if the stone is soft, I'll keep on dusting. I won't change the setting. But if the stone is not soft, because very often you get a hard core, then I will change it to pop dusting. And for me, I'll start with 0.3, 0.4 joules and a frequency of around between 20 and 50. And then once you have broken the stone, when you want that pop dusting effect, then I will switch to about 0.6, 0.8, and the frequency adjusted to again between sort of 20 and 50. So now you can see the stone is broken, but the inner core is hard, and I will switch to pop dusting. And essentially, you just keep it there at a safe distance and let the whirlpool effect, the pop dusting effect work, and you really get fine dust at the end. And I think that's, especially in the kidney, where if you're in the calyx, if you've got irrigation going, then I think the effective temperature, I'm not sure whether it is overplayed, but certainly I don't worry too much when I'm doing this. We've done the same in the pediatric setting. As I said, the dusting and pop dusting settings are as I've said. And in the pediatric setting, this was the preliminary study what we had done. And again, for stone size of about 12 millimeter, we had good outcomes. Thulium laser, we've just heard from Ben, so I'm not going to go over it again, but essentially it is slightly smaller, works slightly differently. You have the pulse frequency is different to holmium. You can go up to 2000, of course, that was initially, but now we know that we don't have to go that high. Some advantages, it is faster, finer dust, etc., and smaller fibers can be used. So essentially, you get more deflection. And all of these probably would be advantage. I'm going to share some of our data on pediatric stones now. So this is one of our studies which we had done about 3 or 4 years ago. And we had 102 procedures in 81 patients with a mean age of 9 years. And really, most of them renal, especially in lower pole, quite a lot of multiple stones. access sheet used in 20% of cases, and really good stone-free rate. I mean, we do stage the procedures just like you do in adults. Complications very low, and readmissions, one patient came back. So I think uretroscopy pediatrics, I think really now guidelines should be revisited on where we stand. And this is how we do it. We combine together, discuss them jointly in MDT with a pediatric urologist and myself in the OR. Again, we are doing it jointly, and I think we've got very good outcomes. And this is now a model which is adopted in several centers in the UK and probably should be a good model for the others to adopt. When you look at access sheet, pediatric access sheets have been used, and people are scared. This is the combined data between us and Barcelona in about 50 patients. And stone size, overall stone burden, when we talk about size, more than 1.5 centimeter, 2/3 of them had multiple stones, a lot in the lower pole. Stone-free rate was quite good, 100% final stone-free rate when we used the access sheet. Although some patients did need second procedure for achieving this. And there's one minor injury which settled with stent, and there was one UTI post-op. So I think, again, outcomes are quite good. So access sheet can be used safely in pediatrics. And this is one of our data on long-term follow-up of using access sheets with a mean age of 12 years. Again, large stones. I normally use the smallest access sheet that will do the job, which for me is 9.5, 11.5 in pediatric patients. Again, we had no complications and very good stone-free rate. So I think the stone-free rate is generally quite good, and this was over a mean follow-up of 26 months, which means the stricture, the belief that you can have strictures. I think if you use it carefully and if you're cautious, stricture rate is actually minimal or non-existent. When we look at the pediatric review as such, 6 years seem to be the cutoff below which the failure rate is much higher and the complication rates are also much higher. So be careful in the very young, and those are the patients where you might need to pre-stent or you might need to change your tack, because the failure rate and complications can be high in this age group. What about low pole stones? We looked at the low pole stone data again, 57 patients with 68 procedures, mean age of 10 years. Again, quite a lot of them with multiple stones, stone size broadly around a centimeter. The post-op stent rates are much lower, at least in my hands, for pediatrics compared to adults, because pediatric patients do pass the fragments probably a lot better. And access sheet use quite a lot of them, especially when we're doing the low pole. Again, good stone-free rate and complications mainly related to urinary infections. So just to recap, pediatric patients can be treated with access sheet, low pole stones, and stones in any location really, and with good outcomes. Just to say that this is not changing the concept with the 7.5 French scopes that are now available. And this was in adult cases from Nadiad. And they showed very clearly that, the smaller scopes can be introduced with smaller sheets, but with similar vision, deflection, and ability to maneuver between both the groups, standard versus the smaller scope. And I think same principle applies in the pediatrics, and we are using more and more of the smaller piece and scopes now. What about volumes? What volume can you say you can do it safely? We looked at the volumes, and actually, if you've got anywhere between 25 to 50 case experience, then your volumes are good enough and your uretroscopy is safe. If you've really got very low volumes, then you probably not, but otherwise medium volumes can achieve similar stone-free rate and safety profiles. Large stones, again, we looked at initially large stone, we defined it as 1 centimeter for pediatrics. We know now that the timelines have shifted. This was about 7 years ago. And again, really good outcomes, stone-free rate and no complications. This is a more recent paper that was published, and Vineet coordinated this in the pediatric setting. Big data set, mean stone size of over a centimeter, access sheet use in over 50%. And again, that shows that it has increasingly been used. Stone-free rate was acceptable, complications mainly cleave-in 1 and 2. So I think this will again change the concept. And when we stratify it, I think less than 5 years, again, there are many more complications. So beware in the very young. How do I do it from how we couldn't do it? So I think this is my mantra of how we do it. up-to-date imaging and urine culture, antibiotic prophylaxis, always a cystoscopy and safety wire insertion. You do need to do a gentle urethral dilatation in young adults as well. Semi-rigid uretroscopy, we use the smallest one, the wolf scope, over a working guide wire. Access sheath, if need be, keep the irrigation low and operative time low if possible. And overnight ureteric catheter, in a lot of them actually without a formal stent. And this is the future, I think, small ureteroscopes, less pre-stenting, more primary ureteroscopy, less post-op stenting, and really high success rate. And they're readily available. So we have now switched to the Pearson 7.5 entirely, actually, for our pediatric setup. And this has revolutionized the way we do things. And hopefully, this will be a benchmark now for difficult cases, the 7.5 scopes, even in adults. Access sheet suction, just briefly to mention, this has come. The only disadvantage I would say is we haven't tried it in pediatric, but you really need a bigger access sheet. And I'm not sure till they can really minimize it, they will have a role in pediatrics. But the data shows that stone-free rate was much better with using suction with access sheet, especially at 30 days. And the risk of complications, especially infectious complications, much lower. So I think this is something to watch out for in future. We have just recently looked at a systematic review in pediatric access sheet, which is going revisions. And when we looked at all the access sheet placements, really currently based on the data, we can't recommend whether on which cases we can use, but clearly it is a personal preference, and we tend to do it for larger stones really. But the rate of injuries, etc., were much lower than what has been previously reported. So that shouldn't be a worry if you're using it carefully again. But we need more studies in terms of pediatric access sheet use. And that was what we concluded based on this. Smaller scopes, what's the advantage? I think the diameter is much less, so you have better irrigation, which helps visibility, probably which helps with the temperature control, etc., and of course the accessibility itself. So we, as I said, we have already used it. Sorry, this is a repeat slide. So advances in uretroscopy, I think there's lots of advantages: single-use scope, fibers, lasers, simulation, and lots of other things about pulse modulation, irrigation, optics. And I think all of these things will make the uretroscopy really pushing the boundary, especially in pediatric cases. And I think with all of this will come the future where we can have all of this connectivity wirelessly, temperature control, AI, and not to forget sustainability. That's something we really should work on as well. So once again, thank you very much for the invite. It was a real pleasure to join you, and looking forward to the discussions. Thank you.
Okay, thank you, Professor Somani. Next up, we have Professor Traxer, who's with us today. He needs very little introduction, but just for those who are still unaware, he's the Director of Minimally Invasive Surgery at Tenon Hospital in Paris, Professor of Urology there. Very well published and an excellent speaker, and we are waiting to hear talk about pressure and temperature in our areas. Thank you, Professor.
Good morning, everybody, and thank you for the invitation. It's a pleasure for me to be back to the UROFAIR. Thanks. And talking about kidney pressure and temperature, you know, it's really a hot topic actually when we are talking about flexible urethroscopy. My disclosure, I'm a consultant for all those companies. Just a quick question for you. If I'm telling you I'm using 50, now you know, 50 millimeters of mercury to irrigate my kidney. What does it mean for you, 50 millimeters of mercury? To be honest, for me, it's a bit complicated to know. In fact, it represents 70 centimeters of water. So it's a column of water 70 centimeters above you patient. Now, what is the intrarenal pressure during a renal colic? We all know renal colic is due to high pressure into the kidney, but what does it mean in terms of pressure? Do you know? Do you have an idea about this pressure? For you patient coming to the emergency room, it's more or less something between 80 to 1 meter of water. So it's a column of water of more or less 80 centimeter to 100, or 60 to 70 millimeters of mercury. Remember this formula. 1 millimeters of mercury is more or less 1.4 centimeters of water, or 1 centimeter of water, 0.7 millimeters of mercury. Also remember that the collecting system is a virtual cavity with almost nothing inside. Very few millimeters of urine inside. Meaning that the pressure into the kidney is more or less 5 to 10 centimeters of water, actually. Actually, if we put a pressure sensor in our kidney just now, the pressure is super low, 5 to 10. It's really low pressure. That's the mean baseline pressure in all the kidney. Since we irrigate, the pressure increase into the kidney, and most of the time when we do flexible ureteroscopy, the pressure into the kidney is more or less 40 millimeters of mercury. But if you increase the flow by using pump, or if you are using a manual pump to increase the flow, there is a big risk to increase the pressure into the kidney, up to 3 meters of pressure. Remember the renal colic, it's 1 meter. If you force actually manual system or pressure pump, it's possible to generate very high pressure. Remember also that the pressure into the kidney is dependent of the inflow, so it depends of the flow when you irrigate, but it's also dependent of the outflow. If you have a good outflow, you can increase the inflow. But if you have any blockage on the outflow, alongside the scarp or through the ureteral access sheath, if you have any blockage, then it's possible to generate very high pressure, especially if you are using high pressure to irrigate. We know that hyper intrarenal pressure is the main reason for complications, bleeding, hematoma, urinoma, sepsis, the worst complication, and of course pain. When we are treating larger stone, most of the time these larger stones, Staghorn stone, they are infected. It's possible to generate up to 30% of serious infectious complications. And it's mainly due to this intrarenal pressure which generate intrarenal reflux through the papilla to generate these infection complications. High pressure, if the urine is sterile, maybe there's no risk in terms of infection, but it's possible to generate also forniceal rupture. You probably know perfectly this picture on the left when you see this extravasation. What does it mean? It means that you crack actually the fornix. And if you crack the fornix, you will produce some extravasation. We call it urinoma. It's very well known. And a rupture of the collecting system. High pressure is also associated with hematoma. It's possible to produce very severe hematoma into the parenchyma or around the kidney, as you can see on this example. I'm sure that most of you have experienced this kind of post-operative complication. The main reason is hyper pressure into the kidney. Endourology means vision. And to have a clear vision, we need to have a good irrigation. Irrigation, remember that we are supposed to use exclusively saline. Even some people recently said that we can also use sterile water, because sterile water is probably the best liquid in terms of quality of vision, but this is super dangerous. So I think we cannot recommend actually to use sterile water, exclusively saline, to irrigate. Irrigation, you need to inject to clear the system, and as you can see on these pictures, it takes very few minutes to obtain a very clear vision if you inject. We would not recommend to aspirate. Some people, they like, when they are into the kidney, to aspirate, to empty the kidney before they fill the kidney with saline. Remember that if you do this, if you aspirate, especially if you do it quickly, you will deflate the system, you will produce a negative pressure, and then it bleeds. And it's becoming worse and worse. So, recommendation is don't aspirate, take your time, few minutes, just to irrigate, and you will clean naturally the kidney by doing that. 1 centimeter in 20-40 minutes, according to the types of the laser we are using actually, and we have seen in the previous talks that it's possible actually to treat 1 centimeter stone in 20-40 minutes, but it depends on many factors. One of these factors is irrigation. So you need to manage to have a good irrigation actually. In terms of dusting, again, the trick is not to touch the stone, move all the time at the surface of the stone, and also irrigate. If you increase the irrigation, you flush the dust in front of you, and then you can proceed much quicker. Irrigation using a 3.6 Charrière working channel is more or less 40 milliliter per minute if the working channel is empty, and if you are using a pressure to irrigate of 40 centimeter of water, 40 milliliter per minute, it's enough. It's largely enough to work. The problem is that when you insert an instrument into the working channel, the flow is going down. So we need to increase irrigation to obtain a good flow. And there is many ways to do that. We can use gravity. It's possible to ask the nurse also to press on the bag, on the irrigation bag, pressure cuff, possible to use manual system like pump, syringe, also possible to combine gravity together with manual pump. Also some people, they recommend to use automatic pump. What is the best system actually to irrigate? First, if you're using gravity, what do you need to respect in terms of pressure for the gravity? Remember that, as I said before, if you're using, for example, 110 millimeters of mercury, it's in fact an equivalent of 150 centimeters of water for the column of water. If you are using 30 millimeters of mercury, it represents 40. It's okay to obtain a good perfusion, good flow at the tip of the ureteroscope. What is the problem? The problem is if you have any problem in terms of outflow, the maximum of pressure that you will generate into the kidney, on the left, it's 150 meter of pressure, which is really too much for the kidney. On the other side, it will be max 40 centimeters. If you have a good outflow, then you will compensate, and then it's possible to use both. So when you are using some pressure to irrigate, be sure that you have a good outflow just to minimize the pressure into the kidney. 40 centimeters is super safe, actually, because the maximum you will generate would be 40 centimeters into the kidney. It's completely well balanced. Automatic pump. Remember that this pump, they are supposed to be a great tool to regulate actually the pressure. Be careful of the placement of the pump compared to the patient. If you place the pump above the patient of 20 centimeters, if you fix 50 centimeters with the pump, you will have to add the 20. So it's not 50, it's 70. If you place the pump exactly at the same level than your patient, then the pressure is exactly the one that you set on the pump. And if you place the pump below the patient, you will have to reduce the pressure. So it's not 50, it will be 30. And that's what we recommend. Same level or below. But be careful if you place the pump above. This is a very simple trick. What about this kind of system? Can we ask the nurse to press, or can we use this pressure cuff? We did some evaluation. some years ago, when we compared the different systems, can just give you the conclusions that if you are using pressure cuff, or if you ask your nurse to press the back, you will have a huge difference in terms of the pressure that you will generate into the kidney. So actually, we don't recommend to use this kind of system. They are not really trustable. If you're using manual pump, which system is the best? Dr. Proietti did an interesting in vitro evaluation of the different systems. And what she demonstrates, using any kind of system, syringe, manual pump, it's possible to generate very, very high pressure if you don't use it gently, this pressure. All the systems are dangerous and able to generate super high pressure. All the systems using syringe are even more dangerous than systems using like a bowl or tube. The syringe can generate even more pressure. The second conclusion was also that your assistant you are using. Watch your assistant and ask your assistant to use this manual pump very gently. Never force this kind of system. They are super useful, very efficient, but they're also very dangerous. What can we do to decrease the pressure into the kidney? Use intrarenal ureteral access sheath, of course. It's well demonstrated that you will maintain a low intrarenal pressure if you're using ureteral access sheath because it facilitates irrigation, outflow. It's very well known since a long time. It was demonstrated the benefit of ureteral access sheath. It's also demonstrated that if you're using small or big one, there is no big difference in terms of benefit of the outflow when the working channel is occupied by instruments, laser fiber or baskets. It's also very well demonstrated that when we're using ureteral access sheath, you need to use the good endoscope together. It should match with the size of the ureteral access sheath you are using. The best compromise, actually, not to use a big ureteral access sheath, is to use the 10-12 ureteral access sheath with the different endoscopes. It's a good compromise, not too small, and the pressure is relatively acceptable by using this 10-12 ureteral access sheath. What can we do to record intrarenal pressure? You know actually that a new endoscope is available from Boston Scientific, and Dr. Ben Chu already demonstrates that it works perfectly to record the pressure and to adapt irrigation according to that. It's also possible to use this vascular pressure wire. It's already available, commercially available, and that's a good solution actually to record the pressure. Look at this example when we are using this kind of sensor, and it's exactly the same when we are using this LithoView light. When you activate manual pump, you can record the increase of pressure in life. So it means that you can adapt, you can respect some limits that you will fix according to each of you patient, and that's something that you can follow in life. Just to give you an example, that's what we do actually. We are using regularly this pressure wire. It costs less than 100 euro actually. We fix it just beside the safety wire. You can see the orange wire. This is the pressure wire, and we record during the surgery the pressure. Remember this formula. Temperature. Just to conclude, laser and system, both of them generate some temperature into the kidney. When we compare holmium YAG and thulium fiber using exactly the same total power, we generate exactly the same temperature. Remember this formula? The power, and we talked a little bit before about that, is energy by frequency. What is the most important parameter in this formula? The energy per pulse and the total power. I would really recommend not to take care too much about this frequency. And remember that frequency is just to regulate the speed. If you're using high frequency, you are supposed to go faster. If you use low frequency, you go slow. So that's what Ben said. Into the ureter, You need to be precise, so just use low frequency, few pulses, and be sure that you are controlling all the pulses on the stone and not on the mucosa. What is the difference when we are using high power system? The only difference is the possibility to use high frequency. Energy is the same, pulse duration is the same. The only benefit is to have more frequency. But the question is, are you able personally to control more frequency, more pulses? Okay. In the lab, there's no problem. High frequency is all the time more efficient because you go faster. But in the real life, using very high frequency is really difficult because nobody can control high frequency, all the pulses directly on the stone. This is something that I would probably not recommend. This super high frequency, it works perfect in the lab, no discussion. But in the real life, who is able to control actually 400 pulses per second? Nobody is able to do that. So be careful with that. Another problem with this temperature issue, people are very afraid about this elevated temperature. But remember that when we are using high power, there's two problems. We can elevate the temperature, but we have also a lot of pulses, high frequency, and it's possible to damage directly the mucosa. So the problem with this high power laser is two things. We can increase the temperature, we can boil irrigation, but we can also generate a lot of pulses with direct contact on the mucosa. And this is the second problem with this high power energy. For the thulium fiber, that's what I would recommend to you. I would recommend actually to fix energy first, like 0.5, very low frequency. Make a test. If you are happy with the effect, it means that the energy level is good. So now you regulate your speed according to the frequency. You can change frequency. If you are not happy, then you can change the energy. What do we need to control everything? To control this dusting, to aspirate, to control temperature, to control pressure. We need to think about something to aspirate. And when we will obtain a good system to aspirate, we will solve all the problem. The dust for better stone free, we will regulate the pressure, and we will regulate the temperature. And at that time, it will be possible to use much more power to be more efficient and more faster. So today we have some first system to use. They are not perfect, actually, but I must say that something is actually coming. What you see actually on the left is what we do today. When we dust, we have a lot of dust. Vision is difficult. But look at what we will get very soon on the right. This is new system, new endoscopes actually, using thulium fiber, able to dust and able to aspirate at the same time. So it solved the problem of dusting, temperature, and pressure. Thank you for your attention.
Thank you very much, Professor Traxer, for your insightful talk. Next up, we will have a talk by Dr. Said bin Hamri. So he's an experienced urological surgeon from Riyadh in Saudi Arabia. His main interest is in minimally invasive urosurgery, flexible uretroscopy, as well as laser therapy. He was recently appointed the chairman of the Saudi Endourological Group of the Saudi Urological Association. He'll be giving us a talk on RIRS and its complications.
Good morning. Thank you very much to the Singapore Urological Association for the invitation. I was asked to talk about retrograde intrarenal surgeries, complications, and solutions. These are my declarations, and video images were recorded in our center. We have to know that the entry of each operation of the retrograde intrarenal surgeries is the ureter. Ureter is not a simple tubular organ, variable in size, is not a straight organ. We have to know that there is an angle inside the bladder, and it jumps above the psoas to reach the kidney. Grasso in 1998 compared the level of structures, which is the most common problems for the urologist, to 0.5%. In the largest study, 11,000 uretroscopy by the group of the Urological Society proved that the uretroscopy is a benign procedure. Even they reported the same rate of the strictures. Why is that? Because for the last 20 years, we have a new generation of the endoscope, small instruments, a huge improvement of the accessories and the intensive training, learning, and exchange of information, and of course, the experience. Infection, pyelonephritis, subcapsular hemangioma, even blood transfusion could be part of the complication. Transient fever, one of the most common, but it's a banal complication. Some sort of complication, you have to take the patient to the OR or lead him to your colleague of the radiologist where they do embolization and or even a repositioning of the double G stent. Uretroscopy is a benign procedure, it's true, but we have to remember that it might cause the mortality because of the most problems during the uretroscopy. We are talking about septicemia and infection comparing to the PCL where the bleeding was the main problem. So how do they happen and how to prevent them? First of all, patient selection is important. This is a UPJ endopyelotomy done for crossing vessels. Patient end up by intrarenal hematoma and perirenal hematoma. Then you will transfuse your patients, and then you will ask your colleague to embolize this artery. Patient selection is very important. This is a large burden stone. If improper selection, improper basketing, improper lasering, and then you will end up what I call a troxureter. You have to evacuate these stones outside and not to damage the ureter or the kidney. Second point is the large endoscope. We don't have any more a scope larger than 9 French in the semi-rigid. You will end up by a perforation, retroperitoneal perforation, a urinoma as structured by then. This is a patient with a partially avulsed by a huge scope, and then you have to put a drain for the urinoma, nephrostomy, and a double D stent. Force is not objective, it's a subjective, so it's all not only complication to your ureter or the kidney, you might damage your scopes, twisted torque, as you can see in the left side, or damage scopes if you force it, and if it doesn't allow, you do not force it. We don't use any more 10 or 12 French in the semi-rigid. You have companies that they fabricated 6.4, even a small company, another company goes with a small uretroscope, 4.5 French, which represents 1.3 millimeter. In the false passages in the ureter, remember that the most common site of the false passage comes in the medial part. So you can use one of the tricks, Nuplex or tipped oblique catheter or a Coude guide wire, and then go to the lateral part to avoid the impacted stone. And if you have a problem with the impaction, terminate and drain and come again in an integrate fashion and solve your stone without more insult to the ureter. Third point is the lithotripsy. I know in developing countries they are using a lithoclass, but now the laser in developed countries, it's a more fascinating technique, lithotripulsion, and from the center to the surface to reduce the thermal injury to the ureter. This is the lithotripsy done for a patient. If you're not pushing the stone to the kidney, you will push it because of the uterus revulsion, especially in the pactal stone into submucosal part, and you will end up leaving that stone, whether we know or not, and if you literature that the stone will cause fibrosis and a stricture per se in the future. So we have to know that the laser is giving you the chance to hit from the center to the surface to decrease the injury and minimize the insult to the ureter. Do not hesitate to put a stent in case if you have a thermal injury or you suspected that your laser went beyond the limits. This is a laser incision of a renal diverticulum. We call it a Fraley syndrome, where you incise more and you become greedy to open that diverticulum. You will end up by hitting an artery, and the patient will develop a clots, and then you will take him to the radiologist to do embolization. The fourth point, ureteral access sheet, was the most accused instrument in the endocrinology field about the injuries, and we have to just emphasize that ureteral access is very important for 2 points, which is the pressure and in-out for basketing if needed. So the pressure is important. You can see in this article that if you are working with a semi-rigid, you have a very high pressure. If you are working with a sheet like this papers from a group of Birmingham, that working with access sheet will reduce significantly the pressure. This is a picture that we use an access sheet, and you can see this kidney is chronically dilated. So imagine that you are working with a virgin kidney, and kidney nuts will tolerate the pressure. You will end by cracks. So remember that you have a dilemma about increasing the access sheet because your scope is 9 French. So you will have more return fluid, you will have more pressure, you will have more clear vision. But you will have more problems about ureteric injuries. That's why if you reduce ureteral access sheet, you will reduce your ureteral injuries. But if you increase your access sheet, will you reduce the pressure? So the point here is not to reduce or increase your access sheet, is by reducing your ureteroscope. By putting the ureteroscope into 7 French, 8 French, you will have more irrigation by 10, 12, and then you can do both things, reducing the pressure and reducing the injuries to the ureter. Hydrophilic coating is very important. You have to know that ureteral access sheet is for single use, and it's very fine hydrophilic coating that allows you to push and withdraw your access sheet with no problems. And the paper operative Traxer, 46% of the injuries caused by 12-14, 86, we are lucky because 86% of them are just a small abrasion, and he reported in his experience about 0.5 to 1% of the injuries. Why did we discover these injuries? Because of the new modality of imaging that allows us to explore the ureter more and gives an idea about how long the double G stent should stay there, how do we follow the patient in the clinic. And we have to know that most common of the injuries comes in the distal ureter because of the angulation and the entry of the ureter inside the bladder. Moreover, is the narrowest part of the ureter. Other type of injuries, not only that mucosal abrasion or perforation, what about the completely flap circumferential? What about the mucosal embedded stones if you push your right seat? What about the partial avulsion, as you can see in the right side? And not only to the ureter, you can perforate the renal pelvis. At the right side, you can see the scope outside the renal pelvis, and this is the renal pelvis inside. Or you can perforate the intrathecal system, and you see the fat. If you push the ureteral access sheet without a guide wire. So never ever work without a working guide wire or without a safety guide wire, because you want to finish the operation, so you'll end up by damaging the ureter. You did not finish the operation, and you might end by putting a nephrostomy for a patient. Hussein Al-Anizi and the group of the institute did this on the person where they just finalize their comments by limit your time of ureteral access sheet and avoid force if any resistant. If you reduce your access sheet from 12-14 to 10-12, you might reduce your ureteric injuries to the level of 12%. And this will give you an idea. Why should I work with a scope of 9 French? I have to work with a 7 or 8 French. That will allow me to have at least 1.5 to 2 French for more return of fluid. 5 points is the guide wire. Even if it's a hydrophilic and very nice, very small instrument, it might cause an injury. And by then, extravasation, and you will delay the second operation for the patient if you are forcing. So fix the guide wire and do not push it inside. Your guide wire should be in the right place, especially in the impacted stone. Do not be overconfident and push the scope or the access sheets if your guide wire is not in the right place. You can see this is a guide wire in out submucosal, or the left side, it's outside the tract. Guide wire could cause a huge extravasation, despite this is a 0.89 millimeter, as you can see in this slide. Guide wire can go out of the collecting system. There is no problem. You can pull the double G stent. It's a retrosplenic double G stent, like a nephrostomy. But why do we do these double G stents outside the collecting system? Because we don't have a fluoroscopy, or we don't want to use a fluoroscopy. Double G stents in the out of the collecting system completely, as you can see here. This is a double G stent was inserted in the subcapsular space, whether you remove it laparoscopic or percutaneous or retrograde internal surgeries. I did not put the videos because of the time, but this could happen, and put it in mind, this could happen for any urologist. One of the complications that I took from my friend in Mexico, uretroscopy with the uretroduodenal fistula, as you can see here, it could happen if you're not thinking the uretroscopy is a benign procedure, especially for radiated ureter or for the inflammatory bowel diseases. Basket, do not be greedy, do not push, and do not pull. And you can see here, if you pull the fragments inside and putting the ureter and the jeopardized ureter, you can see in the middle the video that you pull the ureter inside, and then you see in the right video that stone, then the ureter will be invaginated inside the uretroscopy, and you will end up by putting the ureter inside a ureter. We call it intussusception, and we have reported 1 or 2 cases. You will end up by, this is the endoscopic vision of the ureteral invagination inside the ureter, and you will end up by replacing the ureter by the bowel segments, and jeopardize the kidney for more insults. So there is no violence in the urology. Be nice. If you cannot retrieve the stone, leave the baskets and then go inside, hit the basket by the laser, or put the laser inside the working channel with the basket and hit the stone in the middle, as you can see in the fourth step. Balloon, we don't use an active dilatation. This is a 3 French for French ureter. You dilate it with a 15 French, so it's a 3-4 times more than its capacity. You will end up by an ugly ureter. So please, no active dilatation or balloon. Put a double G stent, come again. Ureter will be more compliant. Impacted stone, you have to intervene early and do not hit more than 1 or 2 double SWL. Keep the patient near to your observation. If do not delay the operation more than, because the impaction by itself is the most important factor for stone formation. The other point is the irrigation, that we have to know that the sudden or high increase of the intrarenal pressure can cause cracks and can cause subcalcium hematoma, can cause a septicemia, can cause a pilovenous return. We know that the kidney pressure is a very low, between 30 to 40 pressure. This is a simple retrograde pyelography. Imagine this patient is obstructive pyelonephritis. With this degree of force or irrigation, you can cause septicemia, and I've seen patients died from this. Again, this is a study from Wilson, 1990, where they proved that the syringe, it caused 10 times pressure more than the gravity. Use a manual pulsatile irrigation. You have seen here, this is a crying kidney because of the high pressure inside the kidney. Do not be surprised. This comes from the kidney. We call it crying kidney. Cracks, bleeding inside the kidney. You will end up by taking these clots outside, putting the patient into the theater again. And so you have to remember always that the pressure is very important, not only because of the septicemia, as it caused the bleeding as well. Rupture of fornix during the operation. Do not underestimate the power of pressure inside the kidney. Do not underestimate that within a minute or 2 minutes, you will end up by subcapsular hematoma, urinoma. This is within 2 minutes, patient developed subcapsular hematoma. Laser high pressure could gives you an venography. This is a beautiful picture that how much pressure you applied in the kidney. In this study, systemic review, they concluded that reduction of the intrarenal pressure is very important and decrease the operative time in each uretroscopy. One of the catastrophic events that will happen in the centers, this is 2 years after a subcapsular hematoma. Look at the kidney become ugly and atrophied to 17%. So you might lose an organ if you do not calculate the pressure inside. So gravity, do not use a syringe because we don't know about the subjective force that applied by your resident or nurse. Use a pulsatile irrigation, as you can see here, just simple gravity, and then pulsatile to sweep away the particles and enhance the vision. The point here that the wise irrigation control the pressure. A 3 centimeter stone in selective cases you can achieve more if you think about the return fluid, the pressure, and the space between your ureteral access sheet, or whether using access sheet or not, and the size of your endoscope. So again, wise irrigation control pressure is very important to understand the equation of the retrograde intrarenal surgeries. The take-home messages: plan it well. Patient selection is very important. Go smaller with your instruments. Do not adapt your instrument to your patient. Adapt your patient to your instrument. Do not adapt your patient to your instrument. Adapt your instrument to the patient's. Limit operative time. If it doesn't allow you, do not force it. If difficulty, terminate and drain. Explore your ureter always postoperatively. Pre-stent if needed. Do not ignore the return fluid, and every French counts. And remember that the scope 7.5 is not like the scope is 8.5. That every French counts, and surgeons cause complication. Thank you very much.
So we're going to go on next to case presentations. I think Dr. Vinny is going to present a few cases for the panel to discuss. Yeah.
Just when I was getting comfortable with all the lovely talks, and then Saeed comes and scares me. So should I even do uretroscopy? I'm wondering right now, but anyway. So thank you, Dr. Khurshid and Dr. Bhaskar, for joining us live. Good morning, though it's 1 o'clock in UK and early morning 6 o'clock in the US. So we really appreciate you joining us. Okay. So I'm just going to go through 2 cases, if time permits, at least one. We'll try to just look at a few things which are commonly practiced and what we do and just want to know whether it's a similar kind of practice elsewhere. So this was a lady who came to us with absolutely stable, no comorbids. She was quite well. But then she had one episode of colic in April during the COVID time. So we gave her some analgesia, antibiotics. There was a positive culture. And then I scheduled her outpatient to see her for counseling. So that's the CT scan. As you can see, there's a 1.1 centimeter upper pole stone, and then there's a lower pole 1.9 centimeter stone. So maybe I'll address the faculty directly to ask them. I'll start with Professor Traxer. If this patient came to you, would you consider RIRS at all for her?
Yes, I will, because if you calculate the total volume of these two stones, it's 2,500 cubic millimeter. So it means an equivalent of a 15 millimeter stone. So for me, it's okay, up to 4,000 cubic millimeters. So I would go probably for flexi.
So we do pay emphasis on stone volume, is what I gather now. Okay.
And stone composition, of course, but...
Okay. So Dr. Ben, would you consider maybe PCNL or stenting for the patient?
The one thing I would say, definitely not as shockwave, because there's two stones in multiple locations, and one of them's in the lower pole. So I don't think shockwave would be a good option for this patient. If it was just the upper pole stone, I would consider that, but in addition with the lower pole. I think with this, I would also talk to the patient about doing a mini PCNL as well, too, potentially.
So, Dr. Somani, this patient came during COVID times, and just like us, I'm sure you also face an issue. Now, she's symptomatic, but she's, manageable. Would you still stent her, or, just consider seeing her directly for surgery?
I think, Vinit, you have nailed it, because it's COVID time. If you stent her, and with uncertainty, you're causing more problems for her. There's no obstruction, so I would probably pencil her for single or two-stage uretroscopy, or at least I'll counsel her for a two-stage uretroscopy. I think PCNL could be an option, but the angle looks okay for me on the single film that I've seen. So I think uretroscopy should work well. But we do need to just counsel that we might need a second procedure.
And Dr. Ghani, do you like ECIRS for your patients, or just stent them like you showed us and then come back another day?
Hi, Vinny. Yeah, thank you. Nice to see everyone. So just a question on this. So it's a left renal colic. So was there a stone in the ureter? Because we can see there's stones in the kidney.
What you see is just what's there. It's only in the kidney.
Okay, so if there's no stone in the ureter and she just had pain, I wouldn't stent her. And if I could review the axial images, this to me would be a supine, if appropriate. I would do a supine mini PCNL with endoscopic combined, if I need to. But I find I do a fair amount of those now, same day discharge, just like uretroscopy. So they don't spend any time in the hospital. They go home from the recovery unit. And the reason I like those is I really feel I'm more confident in getting the patient completely stone-free.
So you would just advise her on a possibility of ECRS to get her out of the hospital stone-free in a single stage, to summary. Okay, so we discussed the same with her. Just another question, Dr. Heng, would you like to have a negative documented culture in your personal experience if you're planning any procedure, or just treat the UTI in case it's positive?
I think we would probably require it to be a negative culture prior to surgery, if possible.
Professor Traxer, in your RIRS, do you just treat them, or do you, because there's always a dilemma, should I get a negative culture before I proceed? Because when you have a stent, you can seldom get a negative culture.
You mean for the negative culture?
Yes,
yeah,
please.
We always ask for this before. I think that's a very safe message to obtain this negative culture. If it's positive, then you have to treat and to postpone the surgery and to recheck. If it's still positive again and again, then you can probably consider the treatment under antibiotics treatment.
So, keeping that in mind, she had to defer her visit due to COVID, and she called into the clinic as she had pain. We had a teleconsult with her, and unfortunately, the second visit is 3 months later. Now I'm going to see her again. Yukang, would you get a CT scan done for her?
Yeah, because I think before we decide on definitive surgery, right, we need to know whether there's a new stone in the ureter and what's the current situation in the kidney.
Fair enough.
I would repeat.
I followed your advice and I did a CT scan, and now that stone has dropped down and become the ureter. So Palani, what would you tell the patient now? I mean, she's like, because of you, the stones come down and now a non-obstructed kidney is obstructed. Well, not because of you, but generally.
Because of COVID. So, ideally we would have treated her earlier, but obviously certain scenarios lead to the situation. I think the plan would remain. So we would have still offered an ECRS, and we would probably clear the ureteric stone, and we can access the kidney, and of course if we can't, then we proceed to puncture.
So you like ECRS, I know, especially after you met Guido. Would you consider taking her up for a staged ECRS, or would you think it would be good to go in, tackle the stone, then I do a supine PCNL and an ECRS at the same time?
I think it's definitely possible to do it at the same time. But of course, the most important thing which I always consider is when my next elective list is. So if it's far away, then I may have to stent the patient first to treat the emergent symptoms before doing the emergent surgery.
Very right. So we always face this dilemma, should we do it now or can we wait a little longer? I think medical expulsive therapy will not be a good choice for her. Dr. Bhaskar, do you think so?
Well, I think SUSPEND trial showed that MET really doesn't have that much evidence as we believed before. During COVID time, I have to say, you tried to do whatever you could. And you can try MET. The evidence for MET actually, in the current guidelines, is slightly larger stones above 0.5 millimeter, about 5 millimeter in the distal urethra. So you could try MET for her, but the evidence, there's no strong evidence really for that.
So I was just tickling you, but the patient came back and she was agreeable for surgery, but she told me she just wants one surgery. So like everybody else here, I counseled her for an ECRS and a mini PCNL. Dr. Ghani, just wanted to ask you, the second culture is still positive. Am I right in asking her for a mini, or should I counsel her for a proper regular PCNL of 24 French?
I don't think there's any strong data to show that there is an increase in the infectious complication rate with mini PCNL, meaning 16, 17, 18 French sizes. So I think as long as you have that, I can't speak for micro and ultra mini, which, are smaller tract sizes, but I think the conventional standard mini, I wouldn't be concerned about infectious complication. If anything, I'd be more concerned with infectious complication with uretroscopy in patients who have prior history of sepsis. Because, of outflow drainage, and so I still think your approach is reasonable. But one thing I would tell the patient is, look, you have a 1.6 centimeter stone in the distal ureter. How long do you think that's going to take you to do? We think it will be straightforward, but it could be tricky and it could take longer than you imagine. So I think you do need to set expectation that maybe all you'll be able to do is do the ureteral stone, but for sure, many patients, they just want to be in the hospital, have that one anesthetic, and have everything done.
And should I re-image her, or just this is good enough for me to go ahead? Or in your practice, do you like to do a CT urogram if you're planning ECRS versus RIRS?
No, many years ago, I was really fixated on CT urography for planning PCNL. I don't think that's necessary. Maybe in the really odd anatomy case that's important, but I think a recent CT is fine.
So we took it up for surgery, promised her that we'll get her stone free in one sitting without over-promising her. And I go there and there's no stone in the ureter, and I searched hard. I promise you there was no stone. And then I find this capacious system. So at this point of time, I'm thinking to myself, this is a very well dilated system. It's perfect. Prof, Traxer, that's a beautiful system. I know you like RIRS. Am I right to consider RIRS, or should I consider PCNL because that's an infected system still?
No, I think if you feel comfortable with Flexi, I would still go for Flexi in this situation. Always good to be ready to switch for mini PCNL if the patient is well informed about that. So you can place the patient in supine position, and then you have all possible options. But looking at this collecting system, I see no reason actually to fail using Flexi.
Because just now you spoke about pressures and temperatures. So I was now beginning to think whether I did the right thing. So in this case, what would be your ideal access sheet?
The patient is not pre-stent, so it means that the ureter is probably relatively small. So I would like to use a 10-12, because for me that's the best compromise actually. It's not too big, but not too small to accept my endoscope. So 10-12 probably. For sure, I will never force to place. So if I cannot place a ureteral access sheet, I will not stop my procedure. I will accept to go over the wire, minimizing my irrigation, not to increase too much pressure into the system, and just proceed.
Okay. So I work with my boss, Professor Heng over here. And he loves PCN and I love RIRS. And we're always debating what to do. So I told him I said, I'm doing an RIRS because I train with you. So I did an RIRS. Very nice. I could access the stone very clearly. At this point, I just wanted to ask Dr. Ben, do you practice sending a urine culture or a stone for culture, please?
So this whole positive culture thing has really thrown a different mix into this whole case. And I think, is this just a positive lower urinary tract cystitis, or is the patient really septic? Because if they are septic, I think you need to put a stent in and come back another time. But I think that would be seen with the patient having a fever or a really elevated white count. It seems like it's and then if they are, if it's a Staghorn, sometimes you can't get them stone or infection free until you get rid of the stone. So that's the problem with this, with other cases. But this one, I think it's a red herring. I think you can go ahead and treat all this. We don't routinely do that when we get in, but if it looks funny, I will send it off for both the urine culture. I've sent off stone cultures, but I don't know if other hospitals have this problem that sometimes they have difficulties processing it, and some of them you have to mash up the stone and crush it up and do other things. But urine culture I will send off if it looks funny inside, sure. But if it doesn't, I'll leave it alone.
All right. So now I've decided, Dr. Bhaskar, and which scope do you think is better? Should I use a reusable scope or a single-use scope, because this is probably an infected system which is treated with antibiotics?
Well, I mean, I think that's a really personal choice and what you have in your department, I would say. But this is almost a 2-centimeter stone in the lower pole, previous history of infection. I think a single-use scope is a good choice for this one, particularly in terms of the anatomy. But it depends again, and so you've got a 7.5 French scope. I think increasingly, I would go smaller, because if the rest of the parameters, as has been shown, are similar between the scopes, why go for larger scope? Smaller scope is better irrigation as well, if you have got a sheet. So I would probably go with a single use for this one. Yeah.
So, Professor Traxer, I was confused. Now, I have a small 9.5 French scope, a sheet, a 9.5 10 French Cook flexor sheet available for me. And I also have that 1113 Cleopatra suction access sheet available for me. Which one should I choose for this case? Is there something in your experience that a suction sheet is better in certain cases, or it doesn't matter really?
Which scope are you using?
So I have the Cook's 9.5.
That's the access sheet.
Yes, please.
The 9.5. And the scope is the 7.5 from Pusen?
So we decided to use the 7.5.
Okay, so I think if you're using the 7.5, with the 9.5 access sheet from Cook, the 9.5, 11.5, and you have maybe seen my graph that I presented, the compromise is just on the limit. It means that the outflow is not so high, actually. If you would like to obtain the best outflow, the 10-12 is actually superior. And of course, if you are using 11-13, it's even better. But I would say, I would still recommend with the 7.5 to use 10-12 at the minimum, and not the 9.5. Because the 7.5 from Pusen is the same than the Flexix 2 from Storz, 7.5, and it's what we obtained. So I would still recommend 10-12.
Sure. So I followed your recommendation and I used a bigger access sheet. Now, Dr. Ben, we are back to this. I know you haven't used, I won't go into too many details here, but I think both Dr. Ghani and Dr. Ben will agree, depends on what you have in your center. Either laser works, Moses is good enough, and TFL is also good. Dr. Ghani, Moses, agreeable? I'm sure.
I have access to both. I have access to fiber dust as well. So I'm spoiled for choice. And sometimes, we ask ourselves, okay, what should we bring out for this case? And there are a couple of factors. I think Dr. Chu mentioned about that side fire aspect of the holmium, which really is the ability of holmium to sort of fracture and hit things further away and bring them to you if you need to. And so if I feel there are elements of the kidney stone case that I need that aspect, then I'm going to go for the holmium and the Moses. So for this case, the angle doesn't look too bad. So I would still stick with the holmium. If the angle was really tight, really difficult angle, I do agree the thulium 150 fiber is very helpful in really tough lower poles. However, I find that you get through the angle, but then with thulium, you really, really need to be touching that stone and getting on the stone. And sometimes that's the other challenge. So I'm a little bit torn sometimes about that. But generally, if I can't make up my mind, I just go for certainty with the holmium.
So Dr. Ben, she didn't go to the US, she didn't come to Canada, she came to us. So I started doing this, and then I was thinking to myself, should I dust this stone, or should I really just basket it, break it, and take it out? Looking at the lower pole, looking at the sound speed, just keeping the whole scenario, do you think fragmenting and removing them is better, or still dusting is good enough?
I've always been a duster, and I think that's a bigger stone as well too, so it's going to take you a longer time to basket all that out. And I think with these new lasers, they just dust so well. So it's funny that Khurshid goes with the holmium first, but I think I'm more familiar with TFL, so I would put the TFL in first, and then notice that if the angle is too difficult and I can't get the side firing and I need to move pieces out, then I will switch over to holmium. But with that in the lower pole, I would like to try and fragment them and bring the pieces up into an upper pole. I never try to laser in the renal pelvis if possible. It's just too big an area, because the pop dusting works so well with these new lasers that you have to get them into a calyx to get the flow going around, and I think it's better that way.
Great. I think there are plenty of pointers on how we should use and what we should use. So we went ahead, and then I put a suction access sheet because I had an access to it. And 30 minutes later, I was so happy when I just looked at an RPG picture over there. I thought to myself, wow, I've done everything. So at this point of time, Palani, I'm quite confident of telling my patient, look, I didn't extract it, I dusted it fully. I just took a small analysis, and I played by the rules, and I did the right thing, what we have learned this morning. Is this picture good enough for me to be convincingly telling the patient that you're stone free, or do you think RPG is not good enough? Because I'm looking at it, I'm also doing an RPG.
Yeah, I mean, if there's no dust when you see it, it's quite convincing. But usually there's some small fragments, be it 1-2 millimeters, and that's the problem. And that you probably need to wait and watch. So they should pass, and technically probably you need a CT to be very sure about stone-free rates.
Vineet, do you ever get the patients to go upside down to try and pass the pieces
So
up afterwards?
I don't do Professor Mantu's technique of the T-tilt. I actually do what we call as the MEL position. We presented this in the AUA 10 years ago. So we put a patient head up. And we actually find gravity helps better that way. We also use gated respiration. So I was just, we are doing a study now. We're looking at the different positions of the tables, whether this is best or that is best. I think there's no real honest answer for dust. It goes everywhere. It doesn't matter how you dust. The dust settles down, the dust settles up, it sticks to the mucosa. So dusting has probably changed. Prof.
My question would be, though, if you turn the patients up, if you tell them to go upside down after the operation when they go home.
Yes, so one of our consultants a long time ago for ESWL showed that, you have a very good ability to clear fragments after ESWL by using the PID, the percutaneous, the inversion diuresis. So we do tell our patients to skip. I don't ask them to do a handstand, but I personally just tell them if you can skip, you can skip. Good. You juggle a little bit, the fragments come out. Yes, Prof. Sorry, I interrupted you. You were saying something. you were going to say something, Prof.
Yeah, no. Just to remember that when the patient is under the table, there is no more lower pole and upper pole. Huh?
Yes.
Remember that the kidney is horizontal. We have posterior calyces and anterior calyces. Okay?
Right.
And it's super easy actually to flush. When you have fragments in the lower pole, you just flush using manual pump or syringe to flush the dust to the small fragments from the lower pole into the pelvis or the upper pole.
Thank you.
I think it's
a very
something we
valid
need
point.
to consider, this lower pole.
Yeah, and may I just add something to that, Vinny, which is, and I think, Ben had mentioned about moving pieces here and there. I just very rarely now will do any movement. I will do a lot of in situ laser lithotripsy and then flush at the end, and then if I can't get things flushed out, I may have to use a basket then.
So I think also important to note is don't flush in the beginning. You can cause a calyceal, fornicial rupture. So just finish your procedure and then gently evacuate the fragments would be important. So anyway, I was happy, no filling defect, and the picture looked good. So I told the patient, yeah, great. So, we just discussed this. People don't stent, people put in a dangler. Professor Bhaskar, do you put in a stent with dangler as Dr. Gurshid was doing? Do you put in a stent with a thread to take it out the next day, or stent everybody and come back to remove it?
Well, I think we shouldn't be stenting everybody for starters. We should stent if it's, you had 2 stones here, low pole, reasonable stone burden, previous history infection. I would probably stent this case on the merit of that. Stent with a dangler, there is a 10% expulsion rate for stent with danglers. That's what the evidence shows. So if you really think she needs a stent for a week or whatever, I would probably leave a proper stent. Usually stent with strings, we leave it, but in those cases, really the question is, did they need a stent in the first place? Sometimes we're leaving it because it's a compromise and they probably didn't need it in the first place. So for this case, I'd probably leave it for 7 days or so. There's lots of reason why I would do that, but I wouldn't routinely stent people.
So you're in private practice, and if this patient had come to you, would you repeat a CT, or would you put, let's just say we put in a stent, and then she's asking you, you're going to see me again for stent removal directly, X-ray good enough, or ultrasound, or CT scan?
Yeah, I'll probably just get ultrasound.
Just an ultrasound?
Yeah.
What about you, Uwe, in your hospital? Do you, still like the ultrasound, or you trust the CT scan better?
Yeah, so for this patient, we didn't, if I recall, we didn't get to see the X-ray, but I remember it's about 800 Hounsfield units, so I'm not sure how well it shows up on the X-ray. So for most patients who have radiopaque stone pre-op, I just get an X-ray. But if I'm uncertain, then I'll get both an X-ray and ultrasound.
So is that fair enough, Prof. Traxer, that if you have an X-ray before, you use an X-ray for comparison, or you have to have a CT scan before and a CT scan for comparison?
No, I think if you leave a stent for a few days first, there's no need to leave the stent for a long time. So at the time when I remove the double G, I like to have a regular KUB together with ultrasound. For me, it's enough, largely enough to make my decision. But I would do a new CT at 3 months at the same time when I do my metabolic evaluation.
Right, that's a very good way to go. So I did this, and the stent was placed, and stone analysis showed uric acid stone, which I didn't believe. But then I took it up for a metabolic workup, and then she was started on treatment. But that apart, 3 weeks later, when she came with a low-dose CT-KUB, so I find these little fragments there in the lower pole, and I was, feeling a little disappointed, disheartened. 1.6 centimeter stone and 1 centimeter still remaining behind. I really didn't know what I did inside with RIRS. Probably I wasn't that efficient. But then my boss told me, he said, hey, let's go back to our philosophy of doing maybe, ESWL for this, or should we go? I told you to do a PCNL, but then at the point of it, Dr. Hing, what would you tell the patient now? Because she doesn't trust me, she came to you.
She did? I don't know.
Would you just remove the stent?
This is done at how long after this?
So this was done about 3 weeks after the first CT scan, 3 weeks later, because I was quite happy on table.
I think what we tend to do nowadays is we'll turn it to the bone window and see how dense these fragments are. And if they tend to be fairly low density, we would actually watch and give a chance for the fragments to come out.
Nice.
Treat this conservatively.
I took out the stent, and then when I looked at the bone window, I took out the stent after that.
Just to know, Dr. Ghani and Dr. Bhaskar, do you all use the bone window at all in your practice?
Yeah, I mean, for stones, I think bone windows are the best if you really want to go through, and most radiologists would use that routinely. I just want to make a point in terms of treatment. You have mentioned lithotripsy. For uric acid proven stones, remember dissolution therapy works really well as well. So you don't always need a surgical treatment. You can observe it, of course, but if it's uric acid stone, it's likely to grow. So dissolution therapy, and I firmly believe, especially for these patients, would work really well as well.
Sure. And what about you, Dr. Ghani? In the US, do we do bone windows or just up to some?
I will do bone window, but I won't do scans of patients who have stents and who are dusted. I never image. I just remove the stent and then I do a CT or ultrasound or KUB whenever weeks later, because these, if you did the case, you know what you did. You broke these stones into small, tiny fragments, and there's not a big 1 centimeter chunk, unless it was a difficult case and you have some doubt in your mind. But that's dust fragments, and so I will just remove the stent and then get a follow-up scan. So I don't have to worry about the dust because I'm not looking for bone windows. But where I find bone windows really helpful is patients who have been stented elsewhere, and you're looking for that ureteral stone, and you want to know, can I just pull out their stent in clinic, or do I have to take them back to the operating room because they still have a fragment in the ureter?
Dr. Ben, I did everything that you guys taught me. I used the right laser, the right scope, I used the suction sheath, I maintained good pressures, I did everything perfectly, and I still got this little fragments in the lower pole. My bone window showed it looks very fine dust compared to the abdominal window. Do you think I can just take out the stent and then see her again? Yes?
Yeah, I think so.
Okay.
And I totally agree with Khurshid. I think that I would, if you knew what was going on and you think you got a good fragmentation, I wouldn't do any imaging until the stent has come out. I think, because this has generated this exact same problem, is that we've taken out the stent, but we haven't had enough time for the pieces to pass. And now we're having this quandary of, do you go in or do you not go back in? And I think every one of us will have had this opportunity where you go back in for what looks like a 2 centimeter stone and it's all just dust sitting there waiting to pass. So I would definitely just wait, put her on alkalization therapy, and then re-CT in 3 to 6 months.
Totally agree. 3 months good enough for you?
Yeah, 3 months.
Okay. So she did not want, obviously, another GA. I took out the stent. I told her what I tell her, skip and exercise. She's pretty fit. And then I counseled her for monitoring what I called it as clinically insignificant residual fragments with a risk of strain stress. So we just discussed this and we decided that we will see her with a CT KUB, and she had medical treatment as Dr. Bhaskar suggested. And 3 months later, which is probably may have been a better option, the CT scan shows there's nothing there. So I think this just was a summary to show how practice we do in different places is similar, maintaining the guidelines, but yet we need to tweak it to where you practice. For the want of time, I think we won't do the next case. We'll proceed to the next part of the discussion, buddy. Yeah, once again, thank you all so much for, taking the discussion through and teaching us, and it was lovely, all your participation, online, offline as well. Thank you very much.
Thank you, everyone.
Do we have time for Q&A? Okay, so you can, would you please help with the Q&A?
I think we have a few options for Q&As. There are some microphones available for anyone in the audience to ask questions. We also have online Q&A. So if you have any questions, you are being shy to stand up and ask for the microphone, you can please post it through the online site. So maybe I just open up the floor. Anyone have any questions, question and answer questions that they may have on their mind at this point in time for our speakers, who are both local and who are locally present and also overseas?
Can we have the mic here, please?
Good morning. Thanks for all the talks. Thoroughly enjoyed them. My question's about the increasing efficiency of lasers and the different sources of energy, because then it would seem to me there should be developments in laser fiber width, affecting our flexibility of the scopes. So with the Moses technology, with the holmium YAG, are fibers coming down in size?
So the question is, your fibers coming down in size, because that seems to be the key?
Well, that's one of the...
Okay.
I think Kershid can answer for the homium system.
Yeah, so thank you for the question. For the Holmium Moses system, the smallest fiber is a 234, and with Holmium, there is a limitation on how small you can get the fiber, outer core diameter. With thulium, that limitation is not there as much, and you can get it as low as 75 micron. So I think that's a major limitation factor for Holmium. The issue I've had with sometimes using, and I think Dr. Chu had it in his slide about inserting it. And in fact, I communicated with Olivia about this, and he told me to cut with the 150 micron thulium is just to cut it flush to make it at the sheet, because I was having some difficulty in getting those into the scope. So I think the smaller the fibers become, the more difficult they get to actually insert and manage in the scopes. And I wouldn't be surprised if you're using reusable scopes that some of those fibers are causing damage to the working channel.
So maybe Ben can talk a little bit about the thulium fiber lasers and sizes that you're dealing with
Well,
now.
I think that Kershid kind of covered that. There is a 150 micron fiber, and it works very well. The beam profile on the thulium fiber is not as heterogeneous as the homium one, so it's more of a coherent beam, so it's easier to make it into a smaller fiber. And you can definitely flex more into the lower pole and better irrigation because you get more flow around the outside of the channel. So I do think that is very helpful, and I think putting that in so you don't break it, I'll have to try your trick about just cutting it, I think would be very helpful.
If I may just ask, Prof, when we cut it, the glass silica tip goes away. Does that make a difference when you don't have a silica tip and just the cladding directly onto the stone versus no?
No, I think it makes absolutely no difference. We did some publication on that when we evaluate if we cut or not the transparent tip. In terms of laser efficiency, absolutely no difference. When you are using this transparent tip at the beginning, it's perfect, of course, for the light transmission. But after a few seconds, few minutes, the burn back damaged the transparent tip. And we need to know the history. Why companies produce laser fiber with a transparent tip? Where does it come? If you ask companies, you will see that most of them, they have no idea. In fact, it comes from the jacket, this blue jacket. At the beginning, it was containing some Teflon particles, meaning that if you don't use the transparent tip, you destroy the blue jacket, and at the same time, you release these particles of Teflon, which is really minimal. But in terms of medical device, it was not acceptable. So the companies, they just removed this blue jacket for a few millimeters, not to produce these Teflon particles. But now, most of this jacket, it doesn't contain anymore this Teflon particles. So this is not a problem anymore to cut this transparent tip. The transparent tip is super dangerous for the working channel. Remember, it's glass. So it's like a spine. So it blocks sometimes into the working channel. What Kershid said before, with a very small 150 micron fiber, if you advance in the working channel, since it's super small, it's not rigid enough, so it's moving into the working channel and it stays stuck into the working channel. If you cut the transparent tip, then the tip is much smooth, and then you can advance the fiber. And it's exactly the same when you are fully deflect in the lower pole. If you cut the transparent tip, there's no need to straight the scope to pass the fiber. You can stay deflect, and you can advance the fiber with no transparent tip. It replaces this ball tip concept.
Thank you. That was important because half the time we are arguing on that, whether we should cut the fiber or don't cut the fiber.
What do you do?
I cut the tip straight away and I use it. I also just use a scissor to cut it. I don't use anything.
Regular
So
scissors.
we've got a few more questions. Maybe Zhongwen.
Hello, thanks. I have a question for Dr. Ghani. I posted this online as well, so I'll ask it live. Thanks for your talk. I keep learning new things when I listen to you. Regarding the Moses fiber, can the Moses fiber be cut if there's burn back? And does that affect the Moses performance?
Okay, so we're back on the subject with the fiber and the tip. I don't have any burn back when I use the Moses fiber. And so maybe it's because of the settings that I use, but the burn back is non-existent with Moses, with that multi-pulse, because you see, when you see what happens on the high-speed imaging, the collapse of the bubble at the fiber tip with the stone is what leads to degradation. When you have the collapse of the pulse and it's further away from the fiber, that's a critical factor. So that's one of the reasons I think the multi-pulse systems will have less burn back. I, with holmium, have been using an unadulterated fiber tip. I don't cut flush. If I do get some burn back because I've used excessive energy, difficult case, long case for some reason, I will cut the fiber with flush with the scissors and the sheath. So the other thing with the Moses fiber system is that the Moses laser fiber comes with a ball tip, which is really useful when you're using reusable scopes and lower pole. But that ball tip, that does erode during the case. So you need to be mindful of that. So if it's eroded, you can't use lower pole advantages of inserting it in a deflected scope. So if I have lower pole, multiple locations, I will do lower pole first while my ball tip is still intact.
Thanks for the answer. So let me just take a question from the online submissions. So it's regarding temperature with regards to high power lasers. Dr. Traxer has mentioned that on similar settings, both holmium lasers and thulium fiber lasers generate the same amount of heat. The question from the Q&A is, why do we seem to hear more issues with heat in the thulium fiber than the holmium, which has been around for a bit of time?
I think it's an excellent question, and nobody knows exactly. I will give you my personal feeling. As you know, I think it was last year, 2021, we had some report coming from the States telling us using thulium fiber, we have some thermal injury. We don't know exactly what happened, to be honest. Even you ask the company, give us the data, the exact setting, what was being used to understand. Difficult to obtain this information, actually. When we are talking about this thermal injury, it means that we are using this high power laser. Could be holmium, but let's focus on thulium. What is the way to use high power? It's not by increasing energy. If you are using high power, it means that you are using high frequency. So plenty of pulses per second. And the problem is, if you are using high power, like 30 watts, 40 watts, we know it's too much, and you will create very high temperature into the kidney, into the irrigation. And maybe because the irrigation not boiled, but is super hot, then it's possible to damage the tissue. But nobody knows exactly if it's the reason or not. My explanation is by using this high power, since you are using high frequency, you have plenty of pulses, and for me, the damage was coming from direct contact of the fiber directly on the tissue. And probably that's the reason why they generate this problem with the thulium fiber. But remember that these 3 cases reported by the company, they mentioned this problem on the ureter. And that's what I explained before. Into the ureter, if you're using too much frequency, for sure, some of the pulses will touch the mucosa. Because nobody is able to control 100, 200, 400 pulses per second into the ureter. Impossible. So some will go in the stone, but most of the pulses will touch the mucosa. And at the end, even you are using low energy per pulse, if you do plenty of small lesions, at the end it's a big lesion of the ureter.
Yeah, I think as a matter of caution, most of the newer systems for thulium fiber actually have settings for ureter versus settings for kidney. And the main reason is because they're trying to control your total energy that is going into the system. So if you're starting out, please check the settings with your vendor and make sure you don't use the high power settings in the ureter.
You know, then one of the key messages, all the time we are talking now with low power, and you've seen, and Ben said a very important message. He said into the ureter, no more than 10 watts. We said 10, 12, yes. Into the kidney, 20, 25, it's safe. But it's not only the power, it's also the frequency you are using. Because even with 10 watts, it's possible to use 0.1 joule, 100 hertz. It's 10 watts. And you are not so safe because it's 10 watts. You will be probably not safe because you are using 100. So watch the frequency, because frequency is the speed, and more pulses you have, more pulses will touch the mucosa.
Okay, I think with that, we are running a bit out of time. So I think I just need to...
I just ask Dr. Bhaskar one question.
Sure.
Sorry. Dr. Bhaskar, in children, you have experience with both Moses and some experience with TFL. Your take is still stick to Moses, stick to the technology we know, or shift to TFL?
You know, it's always interesting when we talk about these things. Remember, at the end of these tools, there's a surgeon who needs to use his gray cells, and you do what is safe. And we forget that all these technological advancements use your common sense and logic. And I think it doesn't matter which fiber, which laser. If you're using it safely, it's fine. It's like access sheet. It's like any of these things. If you're safe with that, it's fine. And that's what we do in kids. We try and minimize the temperature, minimize the time, the operative duration, etc. Even more cautiously. But ultimately, I don't think it matters which energy source you use. Just use it wisely and make sure you use whatever tool at your disposal in the best way with all the knowledge and expertise.
Okay, I think thank you for that. And with that, we'll end this session. I just want to thank all the speakers, moderators, and presenters. We're going to take a 10-minute break. So we'll be back in, let's say, 10:50. Okay, and then we'll do the next session on benign prostate hypertrophy. Thank you all.
Thank you, everyone.